All right, thank you, Lisa, so much for that introduction. I just want to talk to everyone tonight about epidemiology and statistics. Okay, I'm trying to forward my slides.
You can use the forward arrow on your keyboard.
Okay, there we go. I had to click, I don't know. So in 2006, I was diagnosed with Hodgkin's lymphoma, and it felt completely random to me. It was almost as if someone was throwing darts at a dartboard, and if it landed on my name, then I was the next one to be diagnosed. As a public health professional, I know that this is not true. Getting cancer is not random. Personally, it may feel random, but the purpose of epidemiology and statistics is to determine if certain exposures cause certain outcomes. And if we can figure this out, we can intervene and reduce the outcome. So Lisa has already introduced me, and just quickly, I have been working with Dr. Timothy Breivik for the past 10 years as a project manager for the PROSE and MAGIC studies, and I'm also a cancer survivor. So I just want to talk about how do we determine that an outcome is not random. So we use epidemiology and statistics to measure the frequency of an outcome in a defined population so that we can identify exposures that increase risk, and then we try to develop research studies to reduce risk and outcome in the community. And I just want to make a note that outcome in epidemiological studies can be almost anything. It can refer to cancer, it can refer to death, injury, gunshot wound, car accident, HIV. Almost any outcome can be studied. But for this discussion, I'm going to refer mainly to disease or cancer as the outcome that we're talking about. But I just wanted to point out that it can be almost anything. So the definition of epidemiology is the study of the distribution and determinants of disease in human populations. So it's just basically the study of who gets a disease and why. And statistics deals with all aspects of the study, including the planning of the data collection, the organization, the analysis, and the interpretation of data. So it's basically a form of mathematics that epidemiologists use to determine who gets a disease and the risks that might be associated with it. So epidemiologists often try to measure disease frequency in populations. We need to know what's going on. We need to know what is normal. So epidemiologists often look for the baseline rate of disease, so we can then decide if things are happening differently than what is expected. So two such measures of disease frequency are known as incidence and prevalence. An incidence measures the appearance of new disease during a specified time period, and prevalence measures the existence of all disease. So basically, incidence means new, and prevalence just means all. And as an example, the incidence of breast cancer in the United States in 2011 was 230,480 cases. And the prevalence of breast cancer on January 1st, 2008 was 2.6 million women. So that's telling us that in 2011, over 230,000 cases of breast cancer were newly diagnosed. But in 2008, there were 2.6 million women that had ever been diagnosed with breast cancer. So incidence conveys information about the risk of developing the disease, but prevalence indicates how widespread the disease is. So prevalence is more, it's more of a measure of the burden of disease on society. And incidence is usually more useful than prevalence in understanding the development of disease. So for example, if an incidence rate of a disease in a population increases, then there's likely a risk factor that's causing the increase. And incidence is actually better expressed as a rate with a denominator. So the incidence rate is defined as the number of new cases of a disease in a population over a period of time. So the numerator is the number of new cases during a specified period of time, and the denominator is the population at risk. So incidence rates are used to make statements about the probability or the risk of a disease. So for example, if a population initially contains 100,000 non-disease women and 124 women develop breast cancer over 1 year of observation, then the incidence rate is 124 cases per 100,000 women per year. And I mentioned a little earlier that if an incidence rate of a disease in a population increases, then there's likely a risk factor that's causing this increase. So this is a hypothetical pedigree, but about 15 to 20 years ago, clinicians and researchers were looking at a pedigree like this one, where the number of cases of cancer seemed to exceed the expected incidence of cancer. Having 4 cases of breast cancer and a diagnosis of ovarian cancer in the same family seemed suspicious. So they were wondering, was it random or was there something causing this? And so scientists developed studies and applied statistics and discovered that no, it was not random, and that there was a genetic risk factor causing these increased number of cancers. And as we all know, it's attributable to a BRCA gene mutation. So who gets the disease and why? So when we look at risk, risk is defined as an indicator of whether or not an exposure is associated with an increased likelihood of developing a disease. And BRCA1 is an example of an exposure that's known to be a risk. It increases the chance of developing certain cancers. Other risk factors can be environmental or genetic, and some examples are smoking, radiation, human papillomavirus, BRCA2. Those are just some risk factors that have been discovered that increase the chance of developing a disease. And you might hear about different types of risk. It can be measured in different ways. A few common types of risks are absolute risk, relative risk, attributable risk, and lifetime risk. So absolute risk is the chance of developing a disease over time. So it's basically synonymous with the incidence of a disease in a population. So it describes the effect of an exposure on an outcome in the general population, and it's not compared to any other risk group. So for example, you have a 50% chance of flipping a coin and getting heads. So your absolute risk is 50%. Or another example is a woman in the general population has a 12% chance of developing breast cancer in her lifetime, or her absolute risk is 12%. So it's just, the important thing to know about absolute risk is that it's not compared to any other risk, it's just the probability of something occurring. On the other hand, relative risk compares the probability of an outcome occurring in 2 separate groups, and it's usually in an exposed group versus a non-exposed group. So the relative risk is an indicator of the strength of the association between an exposure and an outcome. And the relative risk is actually the average risk for the group being studied. So we can look at relative risk in more detail. Another term for relative risk can be risk ratio, because it's the ratio of the risk in the exposed divided by the risk in the unexposed group. So in the majority of epidemiological studies, investigators often resort to this basic 2-by-2 table. And what happens is investigators examine a group of people who have had a certain exposure and a group of people who have not had a certain exposure. And then they observe the group and see how many people develop the disease and how many people do not develop the disease. And the relative risk is calculated by comparing the incidence of disease in these 2 groups. So what exactly is the relative risk telling us about the relationship between the exposure of risk and disease? Well, if the relative risk is equal to 1, then it's telling us that there's no difference in the development of disease between the 2 groups that were being studied. So for example, among BRCA2 mutation carriers, there's no significant association between breastfeeding and breast cancer risk. So the relative risk of a study that was done was close to 1. So it showed that there was no association. If the relative risk is less than 1, then the disease is less likely to occur in the exposed group than in the unexposed group. So it's showing that the factor or the exposure that you're studying is protective. An example of that is oophorectomy and breast cancer. So it's been shown that having an oophorectomy is protective against developing breast cancer. And if the relative risk is greater than 1, then the disease is more likely to occur in the exposed group than in the unexposed group, or the exposure being studied is a risk factor. And an example of that is BRCA1 and breast cancer. So if we want to look at that in more detail to explain the concept of relative risk. We can look at the exposure of BRCA1, and we can look at the outcome breast cancer. And so just as kind of a hypothetical example, researchers followed 2,000 women over their lifetime, and they found that 600 of the 1,000 women who were exposed or had a BRCA1 mutation developed breast cancer, and 120 of the 1,000 women who were unexposed or who had no BRCA1 mutation developed breast cancer. So 60% of the exposed group developed breast cancer, and 120 of the unexposed group developed breast cancer. So if you calculated that, the relative risk turned out to be 5, which is interpreted as a woman who has inherited a mutation in BRCA1 is about 5 times more likely to develop breast cancer than a woman who does not have such a mutation. So another type of risk that I had mentioned is attributable risk. And attributable risk is just the difference in the rate of a condition between the exposed and the unexposed group. So it's just taking the incidence of the two groups that I just talked about and subtracting them as opposed to dividing them. And attributable risk measures the amount of the incidence that can be attributed to one particular factor. And so if we want to look at an example of attributable risk, this is the result of a 10-year cohort study of smoking and coronary heart disease. And so this was an actual study, but researchers followed 6,000 participants, and at the end of their 10-year study, 65 had developed coronary heart disease, 65 of the smokers or the exposed group, and 20 of the non-smokers developed coronary heart disease. So they calculated the incidence rate in the exposed group and the incidence rate in the unexposed group, and they subtracted them. And they came up with 27.5 of 1,000 people. And that's just telling us that the excess incidence of coronary heart disease in smokers that can be attributed to smoking is 27.5 per 1,000 people. Or just said another way, approximately 28 cases of coronary heart disease for every 1,000 people could be avoided if nobody smoked. And just quickly, the lifetime risk, which we often hear about, is just the cumulative incidence over your entire lifetime. So the lifetime risk of breast cancer for a woman in the general population is 12%. So 12% of women in the general population today will be diagnosed with breast cancer at some point during their lifetime. And so what does this risk mean to me personally? I mentioned earlier when we talked about risk that it is the average risk for the group. And when we say that in the general population, a woman has a 12% chance of developing breast cancer, it's actually 1 in 8 women. And so how do I know which one I am? Am I 1 in the 8 or am I 1 of the other 7? And unfortunately, there's no way to know at this time if I'm 1 in the 8 or 1 of the other 7, since the risk that's being reported is the average for a group. But what we do know is that a 12% lifetime risk is much different than a 95% lifetime risk or a less than 1% lifetime risk. And that's very important information. And so I just want to take a minute to discuss the difference between absolute risk and relative risk. I just described them previously, but I just wanted to go over that absolute risk states the risk of developing a disease as opposed to the relative risk, which compares two groups. So many reports that you hear on the news or read in the papers state a relative risk reduction rather than the absolute risk reduction because it often looks like a more impressive finding. For example, a decrease in risk from 4% to 2% is a 50% relative risk reduction, but only a 2% absolute risk reduction. So if the results are referring to a decrease in the relative risk and the absolute risk or the incidence of developing the disease is small, then the actual number of people affected is small. And I know that was kind of a lot to take in, so I just want to go through 2 examples. And this is why sometimes what's reported may sound much more dramatic than it actually is. So another hypothetical situation, but if a news headline reports that a risk is cut in half, so it might say that the risk of developing thyroid cancer is cut in half by new drug A, which sounds very impressive. But if we look at it, and only 2 in 2,000 women will develop thyroid cancer every year. And if a recent study showed that 1 in 2,000 women who took this drug, drug A, over 1 year was diagnosed with thyroid cancer. So the relative risk reduction was 50%, or it was cut in half. But it's actually referring to only 1 in 2,000 women in the entire year who would avoid developing thyroid cancer if all 2,000 women took the drug. And that's a lot of women to take a new drug. So it's just saying that if normally only 2 women of 2,000 women will be diagnosed with breast cancer, or sorry, thyroid cancer, and only 1 in the 2,000 women will avoid being diagnosed with thyroid cancer if all 2,000 women take the drug. And so that's, you know, it sounds like a great headline, but the actual number of people affected is pretty small. And the same thing is important to realize when you hear that that an increase in risk. When I was diagnosed with lymphoma, my sister went to her primary care physician and she told him that, you know, her sister was diagnosed with lymphoma, and he told her that, you know, now that she has a first-degree relative with Hodgkin's lymphoma, then her risk for developing it is now tripled. And she kind of called me in a panic because, you know, it just sounded terrible that now her risk for developing lymphoma had tripled. And when I explained to her that 1 in 100,000 people will actually get Hodgkin's lymphoma in their lifetime, her risk being tripled meant that she was now 3 in 100,000 people, or 1 in 33,000 people that will develop Hodgkin's lymphoma in their lifetime. And explaining it that way to her didn't sound so bad. So I just want you know, you to be cautious when you interpret big headlines or when somebody says something's tripled or cut in half or reduced by 50%. You know, the actual number affected may be small. And then in a couple minutes, I'm going to review some actual studies. But I wanted to mention a few more statistical concepts that are important in understanding research. So you may hear the term statistically significant in research. And in research, significant doesn't necessarily mean important or meaningful as it does in everyday speech. In statistics, a result is called statistically significant if it's unlikely to have occurred by chance, meaning if it's not random. So the significance level is reported as the p-value. And the p-value expresses the probability that the result is not due to chance, and the p-value is set at 5%, which is just an arbitrary value that it was set at. And scientists all use the p-value as a standard way of conveying how confident they are about the truth of a result. So the lower the p-value, the more confident researchers are that their finding of differences is real or significant. So a p-value of less than 5% is reporting a statistically significant result, and a result that might be clinically important. And a 95% confidence interval that is usually shown right after the p-value is a numerical range that's estimated from the sample, and it includes the actual population parameter that's reported, or the estimated reported risk. So, for example, if the relative risk is reported as 0.4, it's referring to a 60% reduction in risk. And if the 95% confidence interval is 0.3 to 0.5, therefore, this is saying with 95% certainty that the risk reduction of what was studied is somewhere between 70 and 50%, with 60% being the actual number reported, but the truth really lies somewhere between a 70% and a 50% risk reduction. And the confidence interval actually tells us a lot about the study power. So the narrower the confidence interval, the more confident the research is regarding the reported estimate. So if you had a confidence interval that was 0.1 to 0.9, the actual truth or the actual estimate is somewhere in there, but that's kind of a wide confidence interval. So it could be anywhere from a 90% to a 10% risk reduction. So the narrower the confidence interval, the more confident you are of the estimate that you're reporting, or the risk reduction, or the risk factor that you're reporting. And so not to overwhelm you, but there's even more statistical terms that I just wanted to discuss before we actually talk about a study. So these are things that you will see mentioned in an article or a paper, and sample size is important for research studies. And the sample size states the number of people being studied, and it has to be appropriate for the incidence of the disease. So if we go back to our hypothetical example of thyroid cancer, and we know that 2 in 2,000 people develop thyroid cancer in 1 year, then we know that we're going to need thousands of people in our study to detect a change in incidence. And so if we only have 500 people on our study, we're not going to see a difference in the number of people who develop thyroid cancer. So the sample size must be appropriate for the incidence of the disease. And the target population, that's the population about which the study is referring to. So the sample being studied needs to be representative of the target population. So for example, in a BRCA1 mutation study, we want to have a good sample of those women with BRCA1 mutations, so the results are applicable to all BRCA1 mutation carriers, or our target population. Since we can't have every single BRCA1 carrier in the study, we want to be sure we have a good representation of them, so our results are applicable to the entire target population. And bias just refers to systematic error, which can influence the results. It can be an error in the design or the conduct of a study. Anything biased is generally one-sided and is considered unfair. An example is selection bias, which is a bias that can occur in the selection of controls. So it's essential that the control group be as much like the disease group as possible, yet also similar to the target population. So for example, if there's a bias towards younger people in recruitment of controls, meaning that the controls are much younger than the cases in the study, then the results may not be as true or as accurate as they could be, and it can be said that the study is biased. The follow-up time is just referring to the amount of time the subjects in the study are observed. So typically, it's from the time that the subjects enroll in the study until the time the study is completed, and it can be reported in years or person years or in months. And there's different types of study designs. There's a case control cohort study, and I'm going to go into the different study designs in more detail. But I just wanted to mention that study designs can be prospective or retrospective. So prospective studies look at a group of people, determine their exposure status, and then follow them over a period of time for the development of disease. So for example, we can observe an exposed group of smokers and an unexposed group of non-smokers, and we can follow them for a period of time to determine the development of lung cancer. And in a retrospective study, it's a study design in which researchers study patients who already have a disease, and then they try to determine if a risk factor may have influenced the development of the disease. So for example, researchers can study a group of lung cancer patients and a group of people without lung cancer, and then they go and learn about their prior smoking habits to determine if there was an association. And so I mention all these things, all these statistical terms, because it's important that you take all of these factors into consideration when calculating risk. And so every study is different. Every study has a different sample size. There may be some bias involved. It's often difficult to avoid bias. Studies have different follow-up times and definitely different study designs. And that's why there are different estimates of risk that come out of different studies. So I know for BRCA1 mutation carriers, there's anywhere between a 60 to an 85% lifetime risk of breast cancer. And those different risks are reported because the studies have used different populations, or all of these factors are different in the study. And so that's why the risks that get reported can be different. And studies get repeated and different groups of people do different studies. So hopefully the results of each study kind of replicate each other. At least they're in the same direction. If one study showed that smoking was protective against lung cancer and another study showed that smoking was a risk factor for lung cancer, we would wonder, which one was true. And so it's important to see that all the studies are showing that the exposure being studied is having the same effect on the outcome. It's just that the exact point estimate depends on all these different factors, and that's why different numbers get reported. Okay, so now that we've reviewed some basic concepts of epidemiology and statistics, how do we put it all together? So a study is designed to investigate disease and risk, and then they're presented in published articles or posters or abstracts. The research article describes the study in detail, and then the abstracts and sometimes poster presentations that are at conferences are summaries of the article or the study. And it's the results from these published studies that can influence clinical guidelines. Sorry. Okay, so in the research article, there's 4 basic components. There's the background, the methods, the results, and the conclusions. And so the background states the question or the hypothesis the researchers are studying. So often clinicians or scientists make observations that lead to a research question, like the pedigree I mentioned earlier. And this is stated as the hypothesis in the background of the paper. So it tells us immediately the exposure and the outcome that are being studied. And an example of a hypothesis is, does oophorectomy reduce the risk of hereditary breast cancer? So that question states the exposure, which is the oophorectomy, and the outcome that's going to be studied, which is breast cancer. The methods part of a paper describes the study population, the case and control subjects, how the information in the study was collected, and how the information was analyzed. And so there's a lot of detailed information in the methods that explains the nitty-gritty of the data collection and how things get calculated. And then the results section details the data and the statistical analysis. It often lists results that were significant, but it can also list results that were found to be not significant. And the results are typically displayed in tables or graphs in the papers. And there's usually a table that lists a comparison of the 2 groups being studied to show that they are similar in characteristics, because there are some characteristics that may influence the development of disease, and you want to make sure that the 2 groups are similar, so there's as little bias as possible. And you might see comparison charts for age, gender, mutation status, things like that, just to make sure the 2 groups are similar in other characteristics besides the exposure you're studying. And the conclusion in the article highlights the significant results that the study found and the methods that may influence clinical practice. So it's basically the bottom line or the takeaway message. And so the last thing I want to discuss is, are the types of research studies that there are. And it's very important to understand the type of research study that was carried out to interpret the results of the study. And so 3 common types of research studies are a case control study, a cohort study, and a randomized control trial. First we're going to talk about the case control study. And so in the case control study, researchers, the first step is to identify 2 different groups. They identify the case group, or those with the disease, and then they identify the control group, or those people without the disease. And then their second step is to determine who is exposed and who is unexposed. And then they can examine the relationship between the exposure and the outcome. So an example of a case control study that I just pulled out of the literature is breastfeeding and the risk of breast cancer in BRCA1 and BRCA2 mutation carriers. And so the background from this article stated the hypothesis, which was basically, is breastfeeding associated with a reduced risk of hereditary breast cancer in women who carry deleterious BRCA1 or BRCA2 mutations? And so the methods part of this article, it described that it was a retrospective case control study. It said the outcome that they were studying, which was breast cancer, and they said that they had 965 breast cancer cases and 965 controls, or women without breast cancer. And then what they did was a questionnaire review or medical records review that compared the breastfeeding habits of these women. And so the results of the study showed that women with BRCA1 mutations who breastfed for more than 1 year were less likely to have breast cancer than those who never breastfed. So they showed that there was a 45% risk reduction, or the odds ratio was 0.55, and the 95% confidence interval was 0.38 to 0.80. And the p-value was less than 0.05. It was reported as 0.001. So this was a significant result that they found for women with BRCA1 mutations. But they also found and reported that there was no such association seen for BRCA2 mutation carriers. So the odds ratio was close to 1, or 0.95, and the 95% confidence interval was very wide. It was 0.56 to 1.59, and the p-value was 0.83. So it was not less than 0.05, and so this was not a significant result. And so I just want to pause for a second, and I don't want to confuse you, but I talked a lot about the relative risk, and now I just mentioned a study that reported an odds ratio. And the odds ratio is very similar to the relative risk, but it's just the odds ratio is calculated when you do a case control study because the incidence of disease can't be determined. So we do not know the incidence in the exposed population because we started with disease and non-disease people. So what is calculated in a case control study is the ratio of the chance that the cases were exposed to the chance that the controls were exposed. But even though different point estimates get reported because it's a different study design, it's important to remember that all of these ratios are still describing the same relationship between the exposure and the disease. So if the odds ratio is equal to 1, it's still showing that there's no association between the exposure and the disease. And if the odds ratio is less than 1, it's showing that it's protective. And if it's greater than 1, it's showing that it's a risk factor. So it's the same interpretation as the relative risk. So what were the researchers able to conclude from the study? So they concluded that women with deleterious BRCA1 mutations who breastfed for a cumulative total of more than 1 year had a statistically significantly reduced risk of breast cancer. And so what does this mean? So clinicians may recommend that women with BRCA1 mutations who are still going to have children, they may recommend that they breastfeed for more than 1 year as a way of reducing their breast cancer risk. And for women with BRCA2 mutations, the researchers concluded that there was no association between breastfeeding and breast cancer risk based on this particular study. So it was not shown to be protective like it is for BRCA1 mutation carriers, but it was also not shown to be a risk factor, which is also useful information. So the second type of study I mentioned is a cohort study. And a cohort is a group of subjects who have shared an event together during a certain time span. So in cohort studies, researchers follow a group or a cohort over a period of time. They collect information relevant to the disease. They monitor the group for a specific exposure, and then they follow them for the development of the disease. And so an example of a cohort study is the PROSE study, which is the study that we mentioned earlier that I work on with Dr. Rebick. And it's a study that has been going on for over 13 years now. And the goal of the PROSE study is to estimate, or just one of the goals of the PROSE study, is to estimate breast and ovarian cancer risk reduction after the use of risk reduction surgery in women who carry BRCA1 and BRCA2 mutations. And so we have published a number of papers on this topic, and one paper I just wanted to use as an example is the association of risk-reducing surgery in BRCA1 or BRCA2 mutation carriers with cancer risk and mortality. So this paper was published in 2010 and used our PROSE cohort. So in the paper, we describe our objective, which was to estimate risk and mortality reduction stratified by mutation and prior cancer status. And in our methods, we described that it was a prospective multi-center cohort study. There's 22 centers involved in PROSE. And in this particular analysis, there were 2,482 women with BRCA1 or BRCA2 mutations that we studied. And we looked at two exposures, mastectomy and salpingo-oophorectomy. And we looked at a number of outcomes, which was breast and ovarian cancer, cancer-specific mortality, and overall mortality. And we actually call this the Grande paper because we looked at a lot of different scenarios with the exposures and the outcomes. But for simplicity, I'm just going to focus on one scenario, which was risk-reducing salpingo-oophorectomy and mortality. So in this particular example, our exposed group included 993 women with an oophorectomy and 489 women without an oophorectomy. And our participants were observed from the time of their center ascertainment until the end of the study period, or until the event of interest, which in this case was death. So our results revealed that those who had the surgery had a 3% incidence of mortality, and those who did not have the surgery had a 10% incidence of mortality. And so our results were able to report a 60% reduction in risk, or compared with women who did not undergo risk-reducing salpingo-oophorectomy, undergoing salpingo-oophorectomy was associated with lower all-cause mortality. So it was 10% versus 3%, and our hazard ratio was 0.4, or a 60% risk reduction, and our 95% confidence interval was 0.26 to 0.61, and our p-value was less than 0.05. And so like I did with the odds ratio, I mentioned a hazard ratio, which was the parameter that I reported in this study. And the hazard ratio is just a specific type of a relative risk that gets calculated when using a statistical technique known as survival analysis. And survival analysis is used when the follow-up time differs in individuals within the study. So not every person can be studied for exactly 1 year. And so survival analysis accounts for the reality that some subjects may drop out of the study before the event of interest happens, or that the study may end before all of the subjects experience the event. But the same thing applies for the hazard ratio as it does for the relative risk and the odds ratio. So if it's equal to 1, there's no association. In this case, it was less than 1, so it was protective. Or if the hazard ratio is greater than 1, it's an increased risk. So we were able to conclude, or just one of the conclusions we had in this particular paper was among a cohort of women with BRCA1 and BRCA2 mutations, the use of risk-reducing salpingo-oophorectomy was associated with a lower risk of death. And so the last type of research study I just want to summarize is a randomized clinical trial. And in randomized clinical trials, researchers recruit subjects to participate in a study. And once a subject agrees to participate, they are assigned randomly to one of two groups. So they can be assigned to the intervention group, such as the group taking drug A, or a placebo group. And then it's called a randomized control trial because there's no rhyme or reason to whether a woman ends up getting the actual drug or the placebo. And it's prospective in its approach meaning the entire group of participants is followed and then monitored for the outcome of interest. And the idea is that everything else is able to be held constant except for the intervention. So the bias here should be very minimal if there's any at all. And since everything is controlled except for the intervention, the researchers can be very confident that if an association is found, it is real. And so the randomized control trial is considered the gold standard of study types. But there are times when doing a randomized control trial is not ethical or feasible. They typically take a long time, and for example, it's not ethical to randomize someone to receive an oophorectomy or a mastectomy. So I just wanted to mention briefly an example of a randomized clinical trial from the literature, and many of you have probably heard of the STAR trial, which was a study of tamoxifen and raloxifene. And I wasn't going to go through all the details of the STAR trial like I went through the details of the other studies, but I just wanted to point out that the researchers were able to draw some valuable conclusions regarding the use of tamoxifen and raloxifene from this randomized control trial. So they showed that raloxifene was as effective as tamoxifen in reducing the risk of invasive breast cancer. And it had a non-statistically significant higher risk of non-invasive breast cancer. So it did show a higher risk of non-invasive breast cancer, or DCIS, but it was not statistically significant. So so I hope I didn't overwhelm you, but in summary, I just wanted to point out that I hope you now understand that it's not random, and I hope you have a better understanding of risk and how research and statistics are used to determine populations at risk of disease. And I hope you can understand a little bit better when you're reading through an article or listening to a presentation some of the statistical concepts that they're talking about. But just know that really our bottom line is to identify risks so we can try to remove them or use interventions to lower risk so we can decrease the incidence of a disease and impact clinical guidelines and improve the health of the community. So I just wanted to thank you for listening tonight, and I wanted to thank Dr. Rebick for supporting me for the past 10 years. And I've had a great experience working with all the PROSE and MAGIC study professionals and participants over all this time. Actually doing all of these studies is my job, and I really enjoy it. And I'm happy when we're able to report some significant results that can hopefully help people in the future. So thank you very much.